Off to the races. Good evening, everybody. Quick audio check. We'll get started in a couple of seconds. Good evening on the East Coast. Good afternoon on the West. Perfect. Looks like you can see my screen. Chris J.
Yep.
Excellent. All right, ladies and gentlemen, we are recording. We are live. Please throw us in the chat whereabouts you're coming from. Appreciate the time this evening. This is one we've had a bunch of requests on. There's been a ton of questions about how clinics are being built out today, different types of care facilities, let it be GP, post-COVID, derm, cosmetics, OBGYN, right? Surgical centers, etc. The Steri centers, especially with OBGYN these days, is cutting a ton of attention here in Ontario. And really, I couldn't be more excited to have our guest speaker joining us this evening, Chris from Midmark. Chris is a huge resource and advocate, great practical knowledge to share tonight. Chris joins us 16 years worth of medical and dental experience, 2.5 years working with Midmark. Midmark is the go-to equipment provider for all things medical. If you've looked around, if you've gone onto the carts, cabinetries, etc., and/or stereo centers, Midmark probably has touched it. So Chris is a huge wealth of knowledge. Is usually involved with about 70 to 80 medical clinic build outs, renovations, relocations, etc. per year. So as it pertains to design, ergonomics, what's happening now with AI, eye contact, all of the key pieces, Chris is right on the forefront, and we're truly honored to have you join us. Thanks, Chris.
Thanks for having me.
Appreciate it. Also, Jason Yim, one of our senior consultants here at Cirrus, will dig through a little bit of the data piece as we jump into tonight, because God knows we are too busy being busy. And as my father was a GP physician in Ontario from 74, sold his clinic in 94. There is so much to do these days. It is so much more difficult to run a medical clinic today than it was 5 years prior, than it was 5 years prior to that, than it was 5 years prior to that. So the whole premise and theme of tonight is you're not alone in all of this. Building out a new medical clinic is a challenge. Design, equipment, architecture, what happens, and how do I make sure I don't overpay in rent? We've had some fantastic content. If this is the first one you've joined, we had Dr. Daryl Ginsburg share his large clinic, now soon to be second clinic, because we're working with him to go through, and we've had the privilege of over 32 years supporting doctors across the board. But that being said, let's kick things off. So just to customize, here's a quick intro poll. So to keep it fun, we are live. I know a lot of these are recorded these days, and we will be recording and uploading this if you happen to miss it. But quick little background. Do you own or do you lease your space? Right? What best describes your situation? Are you thinking of purchasing an existing medical clinic, expanding, transitioning, building? What type of primary medical specialty do you practice today? And then a little bit of information about the situation regarding your physical location, and some good information if you are curious about your situation, the rent demographics, or curious about specific trends now in design. There's a quick section here. I'll keep that up here. So thanks so much, gentlemen. Let's jump right in. So the purpose of tonight's webinar, the first is, what do I do, right? Chris, I've got a space. I drove through my local strip mall. I went through a recent medical building. I did a tour. It's a box. What do I do next? So we're going to touch on a bunch of processes, what some of the trends are now for some of the clinical efficiency. Chris has some amazing different layouts and designs, angles of attack, right? Layouts, to make sure that we've got a clear perspective of what now is going on in current clinics as they're being built out. How do I decide on my equipment, right? Hey, I've seen I can buy some used stuff online, right? What's the difference? Why should I make the proactive investment? What sort of reactive costs might I have? What are some issues if I do tried to be more budget conscious, but more importantly, how do I make sure I've got the right equipment aligned to the long-term goals of the clinic? And Chris, thank you so much for sharing some of those. The financial side, how do I help to keep as much money into my pocket, right? Which is key. Let it be, not overpaying in rent, helping to have the landlord covered some of the build out costs. Let it be through tenant improvement allowance, landlord works, etc. Huge pieces. Also, how do I make sure that the design aligns with the long-term real estate strategy? Should I buy the real estate? Should I lease? Right? Should I lease my equipment or should I purchase? Right? What's going to be best for me and how to avoid some of those mistakes? Right now, across Canada, especially Vancouver, Toronto, Ottawa, there's just a rash of doctors being forced to relocate, including my own kid's pediatrician, all because of the fact that, some of these older buildings and medical buildings are being demolished and doctors getting stuck. For those of you that haven't joined us before, Cirrus Consulting Group. I'm proud to be the owner, the current custodian here at Cirrus Consulting Group. 32 years in business now, over 13,000. Identical medical office lease negotiation. We're unique. We really are the only healthcare specialized tenant advisory and lease negotiation firm of our kind in North America. This is it. This is all we do is help doctors negotiate or renegotiate their office lease agreements. Again, the real sweet spot is the industry is sort of ripe for some disruption, and typically what happens is most doctors don't realize, but the broker that might have shown you the space or the broker that you called the number on the sign of the local medical building, right, landlord or otherwise, is typically getting a percentage of how much the doctor spends over the term of the lease, including annual increases. So if it's 3 or 4+%, for an average medical office lease, that could easily be 20, 30, $40,000. So very important where we fit in. We only get paid for by the doctor to help negotiate or renegotiate some of these key financial and business terms. The big difference is just follow the money, right? We want to keep, in this situation, you've got your broker, landlord's broker, and the landlord. All three have a vested interest in the more the doctor pays. We are always there to help to make sure, from an element of fairness, that we're keeping as much the base rent as low as possible, the tenant improvement allowance, right? Fair and reasonable without baking it into the rents, and helping to make sure that we get to that great final form lease. Data is key. So I'll pass it to Jason because this, as it pertains to expanding, relocating, renovating, etc., this is the key data to start with. So Jason, if you want to share your screen, you can see if you can bump me out. And let's say I am a physician in Toronto. If I wanted to find out what spaces may be available to relocate my clinic to or open a new clinic, as well as what other clinics might be close by, which is less of an issue. Let's call a spade a spade. We could open up a clinic really anywhere in Ontario, and we'd probably have 100% roster day one. So it's a pretty unique time of such a supply and demand. But Jason, over to you.
Yeah, absolutely. So when it comes to finding the right space, frankly, you're going to need as much information as possible because, like simply put, not every space will meet your requirements. Whether you are looking to open an FHO or whether you're looking to have a surgical suite where you have level 3 type of anesthesia where the patients are sedated and you have procedures that are significantly invasive. This is a very important step, choosing the right location. So how we would look at that as far as this is concerned is, well, as far as the data, if I zoom out a little bit, depending on where you're looking, there's a significant number of locations available, as Eric had mentioned, but really getting down to the nitty-gritty here, determining what will work for your clinic will require a lot more in-depth look. So for example, if I were to dig into this particular building here, allowing it to load, there is a number of key pieces here which we'd want to look for, including what's available right now in terms of the spaces, what they're asking for as far as rent, but also in terms of landlord data. Some of this data I won't share right now because it is proprietary, it's confidential data. But to give you a sense of what we'd be looking at, you know, these are some of the key pieces that we'd want to look for when we're determining what's the right space for you. Additionally, for those that are looking at, selecting an area where you may be the only provider or one of the more exclusive providers in a particular facility. Some of the data we can pull here is looking at other clinics in the area, determining what's the density of other clinicians in a given area. And we can do this based on particular codes depending on what you'd want to do. Eric, anything to add here?
No, it's great. I mean, as you zoom in, you can see suddenly now, where do I want to open my clinic? Where is the closest derm to here, right? What other sort of specialists are working in the area? Sure, there's Google, but this gives a nice view. Jason, if you were to click on any of these or go to one of the other screens, maybe just lastly, the demographics, right? Let's say I do want to target an area that is either closer to my home or that has a certain demographic, or maybe I want to target a certain community within the country. Maybe walk us through how you help to advise doctors specifically about one building, one area, one neighborhood versus another.
Sure. So for clarification, Cirrus, we're not demographers, but this will give you a sense of what the opportunity looks like in a given area. So what we want to look at is things like, for example, population density. What's the growth look like? What's your projected client base? What that will be over the next 5, 10 years in a given area. Also, very important to note things like occupation, income. For those that, for example, will be working with a younger population by age will be very significant. Um, Additionally, household makeup for those that are looking to open FHOs. Perhaps this will be relevant to you. Additionally, very interesting pieces here in terms of employment, getting a sense of uh, what type of industries that people work in a given area. Also, very interesting to note as well is household spend. So we can see here, if you're concerned about what the opportunity looks like monetarily over the next 5, 10, 15 years, this will give you a sense of effectively what the piece of the pie is or what the pie is overall. So we can see here within a 5 kilometer radius of this particular location, healthcare in general is a $351 million industry. Additionally, what we can also see here is per household spend. So an average household within this area, within 5 kilometers, they're spending $2,600 a year. So, you know, this can give you a sense of if you're looking at a particular spot, okay, what's the opportunity here for my business?
Yeah, and I'll pass it back to Chris, but I think that the takeaway here is helping to get a better understanding for what your vision and dream is for, right, providing care to the local community, and then helping to make sure you've got some of the data pieces. We'll talk more about some of the opportunities, especially in Ontario, Bill 60, a lot of the moving out of the hospital and what does that look like to reduce the strain on the hospitals. And how does that work? So if we are looking to add imaging machines, etc. What are we potentially looking to do outside? What does that opportunity look like? That's actually probably a good piece. So Chris, maybe at a high level, what are you seeing for trends? And then I'll get your perspective here on build outs and helping to assemble that medical specific team.
For sure. So I think just kind of with the rumors and talk about Bill 60, it's becoming definitely more of a conversation of surgical centers and more, I guess, alternative centers for being not kind of the mainstay within the hospital itself. Um, so it seems like they're kind of going to be starting with things that are of need. So like hip replacements, and they're just going to keep kind of moving along, basically the different verticals within the medical space for surgeries that are happening that don't need to be done inside a hospital. So I think COVID kind of just showed that we need to change things up a little bit. So I'm hearing more and more chatter just in regards to people looking for space to start designing things that normally would predominantly only be done within a hospital.
Got it. And now you've been heavily involved with new equipment for hospitals as well as the smaller GP practices. Maybe from a trend, what are you seeing of, especially now over the past 3, 4 plus years, an uptick in derm, OBGYN? What are you seeing just at a very high level in terms of trends that's keeping you busy from a build it perspective?
Um, I would say in the past probably 2 years, a lot of cosmetic surgeons and derms seem to be, whether it's their first office and they're building it out to have more operatories within it, or they're adding a second, third location. So I think just kind of going with, I guess, how society is going is becoming a little more, I don't know what to say in terms of, you know what I mean, social media and everything. You get what I'm trying to say, but
Yeah.
definitely an uptick
Beauty
in
conscious.
yes. Um, and then noticing just kind of, I guess, they're like OBGYN, or like pediatrics more and more where it's like multi-doctors within as opposed to just one doctor for a clinic. A lot of times it's two, three, four. And I think for them it's more of a work-life balance thing also because they know their patients will be cared for if they need to take time off or are
Yeah.
not going to be in the clinic. So they seem to be quite happy with their setup. Now, obviously, you need the right partner for that to all work because I've also seen some partnerships end, but that's kind of the trends I've seen within the last 12 months.
Yeah, it's been interesting. I think we've seen equally tons of relocations, certainly plastic surgery, those sorts of things, doing, bringing the ORs to the local communities type thing to help handle a lot of the overflow. And, it was a great example. Dr. Ginsburg was on the last one we did. He shared his case study, started Unify Men's Health with really nothing more, not even a business plan, just himself and a couple of friends from med school that wanted to at the time start a men's medical clinic type thing, and then expanded, and within full rosters within minutes basically of opening. So it was his point of saying, look, it's hard to try to drive the profit. And profit in some cases for new physicians is sort of a four-letter word and is sort of almost frowned upon going through medical school. So the framework here is just, how do we help to protect ourselves? How to make sure we're building a good, lasting clinic? So maybe on this screen here, Chris, this is key. You've seen the good, the bad, the ugly, I'm sure, for build outs and the order of operations, etc. So this I've had up for a couple minutes now. This is a great one. If interested, add to the chat or whatnot. We're happy to send it to you. But Chris, maybe from a best practice, what is a good order of operation? Where do you fit in? Architect, right? Let it be contractor, yourself, right? Ourselves, and the doctor. Maybe your perspectives.
For sure. So a lot of times, just because a lot of people know the Midmark Ritter name, I'm brought into the fold before they even maybe have a site kind of locked down. Other times it's right at the end when they're looking to order equipment. They've already designed the space. They had the contractor there, the architect. So I'm just kind of plug and play at that point. Um, but basically to kind of any of the attendees here to try and get whether it's me, one of my competitors, any of the medical dealers you deal with, to get them involved early just so we can help with whether you're using a designer or with the contractor. Um, for one, ergonomics for you, two, your staff, less steps. If it's planned uh, well from the beginning, it's all about less steps. Trying to get staff nowadays is sometimes not the easiest, so staff turnover or burnout is definitely a thing. So it's an easy way to kind of keep your nurses and your team happy with if they're going to do any sort of thing or walking to the sterilization area. If it's half the amount of steps every time, they're just going to be less tired and be happier throughout the day. So um, but definitely like after they kind of deal with like the lease negotiation, have a site, just have a contractor you trust. If it's a GP clinic, it can kind of be like I see people that use their friends or home builders, and usually you might be able to get away with that if the building's pretty straightforward. If you are into kind of more surgical centers, I would go with a contractor that knows healthcare, just because a lot of things do come up, and typically what I'll see is by the time the clinic opens, it's 3 months after they thought it was going to be, and it's a lot of lost revenue by trying to save 10% on the contractor.
It's a good question we always get is, hey, my uncle's brother's cousins makes, cabinets and they were gonna build out and, build out custom cabinets for me type of thing. Or, oh, hey, I can go to IKEA and they seem to be pretty good these days and look pretty good. What sort of guidance do you do on the equipment and furniture side of things, Chris, in terms of again, let's say it is a OBGYN or a derm or otherwise looking to open up a clinic and try to be cost effective.
Yep, for sure. So, kind of later, I'll show a couple slides just showing kind of some different like room or operatory layouts. But I think thinking big picture and then bringing it in. So, what's the patient interface? Do they have to walk up to reception, go to a triage area, back to their seat between each one, walk down a huge hallway to sit in a waiting room before getting in? So, how do you limit the amount of maneuvering around does the patient do? In terms of equipment, the barrier-free, kind of the powered exam tables or procedure tables are becoming more popular, especially as the population ages. So to have an exam table that goes down to wheelchair height, that's 17, 18 inches, as opposed to being at the fixed height of 30 inches. Patient feedback for that's been amazing. In regards to cabinets, again, GP clinic, family medicine is a little more straightforward. It's more storage, but if you get more into the specialties, having the right flow and where storage is adequate storage, everything where you can just twist and get as opposed to having to get up every time, turn your back to the patient, and bringing everything to you. So a lot mobile carts and wall-mounted laptops or laptops on workstations are becoming very, very popular as opposed to needing to buy a desk in the room, have the stationary computer, and then another chair. Especially for people in the GTA, cost per square foot is pretty expensive, so you might not have the privilege of having very, very large exam rooms. They might be a little tighter. So if we can save a few square feet a bunch of different ways, it makes the room feel a lot bigger.
Perfect. Takes down anxiety and interesting to see how AI is doing. The last few times, physicians talking at me, he's behind away from the computer, and suddenly, AI is listening, treating, recording notes, and God knows what else in the background. But it's a great time. We'll get to that shortly. Again, for those of you that are contemplate that next step. And as a reminder, we have the Q&A is open. So feel free to post any questions as we go. We'll have some time for Q&A in the end. For those of you thinking of or being forced to relocate due to demolitions or otherwise, that business plan is key. Getting a good understanding as to what those capital upfronts are going to be. Thank goodness, RBC, the big banks, they will issue 100% loans and certainly take great care of you throughout the process. They have specific teams that are healthcare focused, so that'd be dental, physicians, right, vet, etc. Choosing the right team, as mentioned before, having a good understanding for those that have done medical build outs and many of them. Site selection obviously becomes very, very important, especially based on leases, financial commitments. As Chris mentioned, cost per square foot is going up and continues to be high. Landlords, many in the space are very specialized for medical, and therefore they know they have premium locations and they negotiate that way. So important that you're not on that teeter-totter and you've got someone to help balance out that equation, of which Cirrus has had the privilege of doing it now for 32 years. The office drawings, right? Making sure that we've negotiated all that data before you sign anything. Definitely make sure, Chris and the team, right, the architect, etc. Let's make sure we can actually build out that surgical suite, right, and or clinic. There's lots of situations where the doctor signed on, and for whatever reason, there might be a need to core, there might be a need to not be able to build out per the specifications. And in some cases, we've seen it where the doctor's been unable to actually open a clinic, even though they purchased it because of electrical requirements and limitations from condo boards or otherwise. So there's so many twists and turns that can be a challenge. At a high level, look, what should the lease do for you? First of all, obviously, fair and affordable rents. It should give you that continuity and predictability of revenue and to make sure that your patients have a place to go, right? And the ability that you can enjoy your time there. This is going to be a large percentage of your personal time and professional time for that matter, which is key. Term stability and security. The last thing you need is mid-career to suddenly have to be forced to pick up, move down the street, move around the corner, because it is just not as easy as rolling out your Midmark chairs and carts, right, and moving them down the street. Not as difficult as dentistry, but still a huge upheaval. Plus, right, working through with the partners, the build out expenses, etc. In such a lower high cost touch of business is key. Minimizing cost and exposure is another big one. And one of the big pieces that I would have each of you make a note of this evening is something called a medical specific death and disability clause. In essence, it's a termination right. You are one of the main sole breadwinners in your clinic, right? Or with a few of your partners. Heaven forbid, if you were to pass away, right? What impact would that have? What many physicians don't realize is the lease is binding to the successors and heirs, etc. And even if they were to sell, or even if they needed to transfer the lease to a future physician or to whomever, right, most don't realize that they will still remain as personally and corporately or continually liable even after that lease is assigned. And there was a devastating example who was, this was a dentist who was north of the GTHA, built out a beautiful 6 operatory clinic. 3 weeks prior to the grand opening, died of a massive heart attack. Fully built out clinic, no doctor, no patients. How much is that clinic worth? Unfortunately, in this case, zero, right? The bank was protected through the life insurance policy, but the spouse was shocked to realize that she was then on the hook for the roughly $9,000 a month, increasing at 4% per year for the remaining 9.5 years on the lease. So the importance of the lease becomes critical to make sure that, heaven forbid, something were to happen, right? There is some protection and it does give you an out. The landlord may have an out for demolition or relocation, but that's key. Saleability of medical clinics has ebbed and flowed over the years. We were involved with that for years. These days, it's tough with such a high demand for the saleability, but still, it's that sort of continuity of care. What's the legacy and what is the plan for the patients? And if you do bring in some partners and then you transition your shares to them over time, right? This is the type of ability to make sure that what does that assignment look like? In some cases, if you bring in a 1/4 partner or there's some sort of a change of control, you must get the landlord's prior written consent. The financial side, the financial side, the financial side, the financial side. It is very difficult these days to make and stretch a dollar within a medical clinic. Costs are exponential, right? The rates that physicians are being paid, especially in Ontario, is low. As my father reminds me, it's almost the same as it was back when he started practicing back in the 70s, which is remarkable to say the least. So, therefore, the cost, the overhead, swinging for the fences. You are the best tenant on the planet. You have some of the highest build out costs. You've got the lowest default rates. You're in the same location for 26.5 years. It truly is remarkable the type of leverage you have. Yet, so many times, physicians don't truly leverage it, right? Or try to get the landlord to cover or pony up, considering many cases it's two, three, four doctors that have signed the lease personally. That landlord is just smiling all the way to the bank, which is okay. But, right, that is a huge amount of commitment that the landlord knows that is just a yellow brick road to make sure that that rent is always paid. Being cautious about tenant improvement allowance, costs, etc., are very important as it pertains to how do we keep as much money into your pocket. Be cautious with taking money from the landlord. If it's, $5 a square foot, $10 a square foot, sounds great, sounds fantastic. Hey, Chris, the landlord's pitching in to do some of the build-out costs. Yes, but landlords aren't in the lending business, and if they have just passed that on to you in the terms of a higher rent, higher annual increase, right? You've basically baked in a loan into your rent that you can never pay off, that just keeps on going up and up and up. Simple example, right? 5,000 a month increasing at 3% over 30 years is a $3 million commitment. So the lease represents the largest check that you will sign in your personal or professional lifetime. Therefore, if you're about to sign a check for $2.9 million, would you not want to make sure that you've squeezed every potential drop out of that? So great, Eric. I guess I'm going to buy my own building. Well, tough to do, right? It can be a great benefit. However, in many cases, talk to physicians that have, it can be just as much of a frustration. You become the landlord, right? You may have other tenants. You may have all sorts of leak issues, plugged toilets, etc. That is not as exciting as it sounds. So be cautious about it. Regardless, you will still need a lease separating the real estate corporation from the practice corporation, even if you do choose to buy. But it is a huge build out cost. And of course, we can all make money in real estate if we live long enough. But most new physicians like the flexibility of being in a other building with, right, a blood service provider, lab, right, and others within the same building. These I'll share for our next a next event and seminar, but ultimately some key questions to make sure that you have tracked in your phone tonight is, do you know when your current lease expires? Are you a personal guarantor? Do you have any options to renew? And if so, do you know your option to renew deadline date? If you miss that date, the remaining options become null and void, right? Are the options transferable to a future buyer? And most importantly, number seven, does your landlord have a termination right? That these days is becoming unbelievably common, which is a huge challenge. How do we structure the new lease? Good news. We will spend the next 4.5 hours going through each and every one of these clauses. Thank you, Chris. I know the kids aren't up watching a movie tonight. This is fantastic. No, just kidding. But these are just some of the dozens and dozens of clauses that we focus on, help advise the doctors in terms of what's fair and reasonable, in terms of how we structure and negotiate these leases. Lastly, one practical example before I pass things over to Chris is here is the dreaded demolition clause. This is one that the banks will absolutely flag and in many cases prevent you from getting the loan to build out that new clinic. What the heck is a demolition clause? Jason, you see these all the time. How would you explain to a mid-career or transitioning physician, what is the impact of the demolition clause and what impact that might that have on assigning the lease or building out a new clinic or being forced to relocate because of this one little provision?
Well, yes, this one little provision can be $1 million decision. That's for sure. So the function of this particular section is, well, it makes the lease a lot more aligned potentially with the landlord's plan to, one, demolish the plaza or building, and two, put up a shiny new condo, for example. That's the long and the short of it. Now, as far as its functionality, the way it would work, there's a number of pieces here that are within the demolition clause that, one, provide the landlord a ton of leverage when it comes to that potential redevelopment piece, and two, puts you the practitioner at an uncomfortable moment when you're faced with the potential task of finding a completely new space to lease. So as you'll see here in this particular section, there are a number of ways that the landlord can make this a very bad day. So one of the big things here, if we look at the first piece of this is, within any, for those that have a clinic right now, this might be very familiar to you. One of the big things is, first of all, the landlord, if they're going to exercise uh, this type of clause, they need to provide you some kind of notice. They need to tell you that they intend to do this. So, in terms of the way this particular example is structured, it indicates here that the landlord will tell you that they intend to demolish or materially alter the project, meaning this may not be an entirely new building. It might even be an addition to the particular building that you're in, and that
Doesn't
would
even mean
require
they
a roof
have
roll.
to. It's just literally they wake up in the morning and they say, "Yeah, I'm thinking about it."
Mhm.
Right? That can be enough to just materially alter the location and remove you. As Jason mentioned, yeah, bang on. It can be as little as 180 days notice, and you are out. You could be 1 year into a 10-year term, and that's it, right? Of which, right, you terminate. There's no compensation. There's no, pass and go. There's no $200. It is you are done and out. And what if there's not a location close by? Right? And in some cases, maybe there is some sort of a credit or otherwise, but very unlikely. And certainly, this is one of the biggest issues we're seeing amongst physicians and medical clinics across the country. Again, the cost can be exorbitant and a huge hit, and a huge amount of personal savings can go towards building towards it. How do we prepare ourselves from all of this? Start the process early. The best time to start a medical renewal negotiation is typically 24 months prior to the lease expiry. When does the average physician start the renewal process? Maybe 2 months prior, right? And of which the landlord knows you can't pick up and relocate a clinic in 2 months, right? Permits, zoning, equipment, layout, design, all key. So to summarize, as we pass to Chris, is number one, get all the information. Do you have a signed copy of your lease and what the lease signed as well, and the landlord signed as well? Have you figured out your practice and career goals? Number three is, right, have your lease reviewed for the risks. So you know what red flags are in there today. As Jason was showing earlier, know the market rent, right? Know the market data. Do you know if you're overpaying in rent or not? Number five, right? Figure out what that carefully choreographed game of chess looks like before we pick up the phone, then negotiate the business, then negotiate the financial clauses. Please do not walk into the clinic tomorrow and say, "Wow, I watched this great webinar with Chris. This is fantastic." And good news, right? Mr. Landlord, how much do you want to charge me next time? Negotiate the financials, negotiate the business clauses, and please do not stop until you get to a final form lease that you and the landlord has signed. Okay, as we pass it to Chris, we certainly appreciate your time. In appreciation for that time, we waive our $2,000 fee to do a complimentary lease review, rent rate analysis, demographic reports. If you've been curious at all, one of the best things that can be done is to get a good understanding specifically for your situation. And if you haven't looked at the rent, if you haven't got some of those components, highly recommend. There's a little section here I popped up just to make it easy. We're happy to follow up, schedule about an hour, no cost to you, to go through some of the specific goals for your situation. All right, on that note, Chris, design, layout, equipment, architecture, do's and don'ts, and best practices. Over to you, sir.
Perfect. Thank you, Eric. Sorry, my computer's crawling here. Okay, you see my screen?
Perfect.
Awesome. So just getting into kind of the design of the clinic. Again, as I kind of mentioned earlier, sometimes by the time we're brought in, at that point, everything's been kind of spoken for, and we're trying to piecemeal to make what's going to be the layout of your clinic the best we can, without obviously moving walls in any way. So it kind of some of the key factors that impact the spatial layout in a space itself. Obviously, number one, the size of the room. Two is going to be the types of procedures you're conducting in the space. So, are you GP, derm, cosmetic surgeon, ENT, lumps and bumps? Um, Obviously, which province or state? I'm not sure if most of the people here are from Ontario, but obviously that's going to dictate as well with local codes. Types of mobility devices. So, is your patient base older? Most people are going to have a walker or wheelchair that are coming in. Increase patient throughput, and then locating proper equipment. So here's just kind of like a good example or starting point on what a typical exam room should look like. Big one that sometimes is an afterthought is you always want the door opening to the middle of the room. Reason being, if someone accidentally walks in while a patient's in there, they're still going to have some privacy, as opposed to them being exposed to the hallway. It also keeps you from needing to install curtains. Usually curtains never get cleaned. They start to get gross pretty quickly. So that's just one thing I do see as an afterthought. A lot of times the door opens to the wall as it would in your house to get it out of the way, but typically in an exam or procedure room, you want it to open to the middle of the room. Enough space in the room for the radius or turning of a wheelchair, or if someone does have a walker. A place obviously where patient family is going to have enough room to sit there as well. So we kind of call it like the exam or procedure space, and then the public space is two separate things, so people aren't getting in the way. And then last and not least, for you being the practitioner itself, is having good ergonomics. So where's the computer located as to where you're going to be sitting while you're interacting with the patient? Your accessible casework. What kind of storage does that look like? Do you have to leave the room to get any supplies? Is everything there? Is everything easy to grab? So that's kind of like just a good overview example. Um, what else we're kind of seeing with a big trend is what's called barrier-free tables. They're essentially powered tables. So you can see kind of here in the bottom right, it's all about the accessible transfer from someone in a wheelchair. I kind of have these different graphics up here just for the sake of all the steps that code has been um, to help people with disabilities. So there's the wheelchair parking spot. We have a ramp for better accessibility for mobile patients. There's the button for the door for wheelchair patients or patients in walkers. There's even lower water fountains. So someone in a wheelchair can grab water, and then they get to the exam room. And I don't know, then and how do they get up to a 30 or 32-inch table? So one, it also takes the strain off your nursing staff or your team that's walking the patient to the room. But two, it just makes the experience a lot better for them. The ADA has actually changed the minimum. It was at 19 inches. They've lowered it to 17, so it's actually 1 inch lower than a wheelchair. So their studies, what they found was at 18 inches, 64% of people could transfer easily. At 17 inches, even though it's only 1 inch lower, 94% of patients can transfer easily, just because instead of it being equal height, it's down. So it's just an easier transfer with weight distribution. Eric alluded to AI, so it's going to probably change over time, especially with how fast everything's adapting and progressing in the world of artificial intelligence. But the big kind of push over the last 2 years has been point of care. So while you're interacting with your patient or doing a procedure or going through preliminary questioning, you should never ever have to break eye contact with your patient. So you should always be able to be focused, more warming feeling, better experience for the patient. So mobile carts, wall-mounted workstations, computers on workstations, as opposed to having that stationary computer at a desk kind of wedged in the corner where they're typing and their back and your back is to them while going through. So again, with AI coming, this might be less important here if it's just going to be transcribing notes and everything, and you as the clinician isn't going to have to interact with your computer so much or use a keyboard. This is the big one I always see overlooked. So again, whether you go with like a medical cabinet company or you use your contractor or a local mill worker or a friend that builds cabinets or IKEA, is having a standardization of how you organize your supplies. So typically the average height of a nurse, at least in North America, is 5'4.5". So a lot of times you see some storage walls and there's shelves way up at the top where they have to get a stool to their tippy toes. And then also the least used cabinet or drawer always is the very bottom one because no one wants to lean over. So a lot of times what you're going to find is you can condense the cabinets. So you're not going to pay as much because it's less cabinetry and you're still going to have the same sort of storage capabilities as well. So it's not going to impact it. But big ones are little things like this, angled shelves. So you can see what's in each of the bins. You can see what's behind. So you know if you need to refill anything. And then using bins themselves, it's just easy to basically walk out of the room, fill it back up, put it back in, and for your inventory control as well. This has become more and more popular, as Eric had alluded to with that OBGYN clinic that was shut down back in April for improper infection control. So this image here is obviously overkill unless it's a really big facility. So for example, I just put something not quite this complex in, but for a very, very large OBGYN clinic in Mississauga. Because before they basically just had a countertop with a washer and a sterilizer, and there was no proper flow. So everything should be flowing from one direction to the other. You should never, in any step of the process, have to backtrack. So this is just an example. Step one, you put your dirty instruments in, and you have your ultrasonic cleaner or a washer to debride your instruments, sink to rinse, and it goes through steps 3 and 4 to sterilize, and then you have clean storage. So you should never have to backtrack from left to right. Or I guess if your stereo center went right to left, you should never have to backtrack going from right to left. It should always be one continuous flow, and then you know you're never going to cross-contaminate in any way. So I've had a lot of calls from different clinics now just because of that scare on getting their sterilization area kind of under control and up to code. I've noticed IPAC, so the Infection Prevention and Control, doing stop-ins as well to try and help educate people as well. So this is kind of becoming, at least in Toronto right now, just because what happened in the spring, a big talking point for clinics when it was a little less looked at before, I guess. Dental's always had very, very strict because all their instruments are dealing with blood and tissue. Now, I know it depends what type of specialty your clinic is for needing something as opposed to just needing a sterilizer. But if you do any procedures and deal with blood and tissue, it is very important just to make sure that you do have a proper layout in terms of what your sterilization area is.
Chris, this was obviously, as you said, overkill. What's a good step one, step two, right? So if you're a doctor similar to what you had mentioned, so it's some countertop type stuff, what's one of the best ways to at least get to, right, sort
Okay,
of
it's a
the
very good
minimum?
question. So I'd say first off, it will just depend. Like I think of my kids, I have a 5 and 6 year old, their pediatric clinic, nothing gets reused. It's just all disposable stuff. So they don't need anything for that matter. Um, Typical GP clinic, they're fine with just kind of a sterilizer, an area to basically put dirty instruments, a sterilizer, and then some sort of clean storage. The big one is the first question I always ask is, do you want a central storage area? Um, or do you store everything in the rooms? Because then we know what kind of size we need for the stereo area. If they store everything in the room, we can now get away with a much, much smaller sterilization area. I know sterilization areas are not revenue generating, so usually people want to have as small a one as possible, which makes sense. You don't want to have to remove an operatory or an exam room to fit a steri center. So typically, if it's a simple clinic, 6, 8 feet is going to be fine for sure. So just an area to put your dirty instruments, a sink, whether you're going to use a soft bristle brush to debride the instrument if it is dealing with blood and tissue, rinse it off in a sink, and then go through the sterilizer, and then basically it would be stored.
Oh, great.
I just wanted to highlight something we offer. So if anyone on here is looking to build, relocate, renovate, we do offer live design with our designers. So again, we are not an architectural firm. We manufacture medical equipment. But if you have architectural drawings, we can really, really, really help from there. So it's basically, it can be a virtual thing, kind of like we're doing now with our designer, and they have 3D renderings. So once we know the size of the room, we're basically able to real time move things around, adjust size of cabinetry, switch drawers, doors, if you want see-through, or if you have narcotics and you want locks on doors or double locking. But it's just a service that we offer at no charge that the feedback we get is very, very good because it really takes a lot of the stress away from you. You have enough stuff going on with trying to procure a space, hire staff, deal with your patients. So this takes it off and you're able to change things real time. So again, just an example of kind of some 3D renderings of what they would show. And I will just show a couple examples here quick. I want to leave some time for Q&A. But just so everyone here is aware, we do have this right on our website here. So basically, if you at midmark.com and you go to the design center, they have different workflows for the type of specialty that you work on. So if we wanted to look at, say, traditional exam, just to give you an example. And it goes through kind of the different points on why it's recommended to do it a certain way. So again, ergonomics, doors going inward. You always typically want to be situated in the office as well, where the doctor or the nurse is closer to the door than the patient, just because if any patients do have any mental health issues or there's some hostility for that reason, it's easier for you to get to the door, you're not blocked in. That's always a big talking point we talk about too, and kind of going through public-private zones. So dual access is getting a little more common as well as more and more clinics have multiple doctors within them. So two different doorways in, one where the doctor enters from and one where the patient enters from. And again, just some in-office workflow I'll get into. So for instance, if anyone is in podiatry or chiropody, but just it's really good, simple things that you can, if you take an idea or two and it helps you over I think you said the average is 26.5 years, Eric. If it can help you over 2.5 decades, do your job easier, better patient experience. It's there for you to use. That's kind of all I had on my end here. And we got a little time for Q&A. So I kind of sped through so we had a little time.
Yeah, no, that's great. I see men's singles are starting soon. Let's go US Open. All great. You know what? These are key pieces because it's a challenge these days. And you know, what are the trends? What's this? And then ergonomics is usually the last thing on the list, which is ironic, considering how much you're sharing that with your patients. So we'll open the Q&A. Certainly appreciate everyone's time. Also, if you would like some more info or some of these designs that did come from Midmark and Chris, I will pull that up here now as a quick piece. And you know, I think some of the biggest Q&A we get a lot of is time. So, Chris, the question to you is, you've seen some of the biggest hospitals to the 120 room now you just did outside of the GTHA, as well as some of the build out, surgical, cosmetic surgery, etc. Timeline wise, what would you share to a doctor that's thinking of relocating or thinking of um, building out, etc.? What are you seeing? Best case, worst case scenario, and then what does that timeline look like from looking for a space, right? Negotiating the lease. I mean, from our side, we're typically saying 18 to 24 months, but maybe from your side, where do you see each step taking, and how long does that take?
Okay, I think kind of once they've found the space, within 6 months is doable unless it's like they're going to use anesthetized, like, you know what I mean? You need generators um, for an actual surgical center. That's going to be longer just because there's way more red tape and permits and things needed when patients are under. For exam, clinic, kind of typical specialist, like 6 months is more than suffice, unless the contractor kind of messes around with you. But in terms of once you get to the equipment and everything, COVID, our lead times were 6 to 8 months on most things. So that extended everything dramatically. Now we're back to 2 weeks for our stuff. So even if it is last minute, we can get it done. But the big one's just the architectural drawings, the permits, and then getting the contractor the time for them to do it. It's not so much the back end stuff, dealing with the actual products or their medical dealer, where that was typically the rate limiting step, always was getting the equipment. It's not that case anymore.
Got it. One question recently, tariffs, Trump tariffs, etc. I'm sure you're getting those questions as well. Chris, what are you seeing on your side, and what impact does that have for you?
So I know it's kind of, I guess right now because of Trump, a faux pas to buy American, but so we are an American company. Everything is manufactured in the US minus circuit boards. They're made in Taiwan. 92% of the parts and materials used in our equipment are from the US as well. So there's nothing affected in terms of us getting goods to build the equipment in terms of tariffs, and there weren't at any point since February, since kind of all this yo-yoing has gone on. Um, and right now, no tariffs seem to be are going to be affecting our stuff, and I don't think Canada's going to want to tariff things that are going to revolve around healthcare also. Um, So there's no worries for that. Back in February, I was a little more worried, but now that I've kind of dust has settled a little bit, it doesn't foreseen to be anything that's gonna affect us.
And it looks better even as this week, right? The reciprocal tariffs look like they've settled down a little bit, which is cooler heads prevail. Um, and the other interesting piece is again back to that Bill 60. One question specifically on services and what does the over the rainbow look like? Are we going to be doing CT scans outside? Are we going to start having full imaging suites outside of the typical hospital type thing? What do you see, Chris, to sort of look over the rainbow? What do you see from a um, future of medical products, medical equipment, medical types of services, and the equipment that comes with us? What do you see now based on your 16 years in the business?
Yeah, I'm seeing more kind of, I guess, like imaging centers where patients can go to, again, keeping it out of the hospital. So the trend seems to be that way. And again, I don't really know whether it's a good thing or bad thing, you know what I mean, long term, but I think it showed like if there's any pandemic or endemic that happens, a lot of people were affected because they couldn't get any services at the hospital,
Yeah,
because our hospitals were so overrun. So I think it's going to continue. It seems like the way the government's doing is with Bill 60, they're choosing things that people aren't really going to say no to, or the public isn't going to say no to. So that's why I kind of said I think it's like hip replaces they're starting with, then they're getting into kind of like mammograms. So things the public isn't going to push back on.
yeah,
I believe that's just more of a foot in the door for the government to keep expanding that,
yeah.
in all honesty.
Yeah, God knows there's lots of baby boomers, and my parents are one of them, and struggling to find the right care at the right time. So perfect. Appreciate it. We are bang on for time. Chris, thank you so much. Really appreciate your time this evening. I know you got lots on the go. But again, it's a great reminder that you're not alone in all of this, doctor. This is, there are experts that do this all day, every day. Chris is a prime example, 70 to 80 different build outs across the board. Chris, I'll pull up the contact information again. What's the best way that people can get a hold of you?
Yeah, of course. Email right there. So I got a kind of hard last name, but it's just C for Chris and my last name at midmark.com is definitely the best way to touch base. Even if it's just any questions at all, I'm more than happy to support
Awesome.
and answer.
Great. And Jason, looks like we've got a handful of requests for some contacts for Midmark, which is great. And Jason Yim, and the best number to get a hold of you, Jason?
Yeah, absolutely. So you can reach me at 647-789-3244. And of
Perfect.
course, my email is listed below.
Great. Chris, thanks again. Thanks so much for your time. Hopefully the kids haven't set fire to the house. And
Agreed. Thanks for having me on. I appreciate it.
have a great day. Thanks,
Appreciate you.
everybody.
Good night.
Thank
Appreciate
you.
your time.
Bye.
Bye now.